discuss the characterization and staging in the management of ocular disease using new biomarkers developed through the study of ocular, and specifically here, vitreous proteomics. A lot of this work is being done at our new laboratory facilities at the University of Maryland Biopark under the auspices of the newly formed Ocular Proteomics, LLC. The main causes of blindness in the Western world include age-related macular degeneration, both dry and wet, diabetic retinopathy, both non-proliferative and proliferative, as well as retinal vein occlusions, including branch retinal veins and diabetic retinopathy is causing increasing levels of blindness because of the epidemic proportions of diabetes in our populations. Population is growing in its incidence because of the aging of the population overall. Mostly, retinal disease, specifically diabetic retinopathy and macular degeneration, have been managed by morphology. We've been really fortunate in ophthalmology to be able to view the fundus, view the retina directly. However, morphology doesn't really tell us the whole story, and we don't have access to the biochemistry of the retinal. Morphology such as OCT and with a lot of insight, but the problems with developing biochemical data for the eye, specifically for the retina, is that first of all, the retina is very, very small, especially the macula area, being only 1.5 millimeters in diameter and about 300 to 400 microns in thickness, is very small compared to the overall rest of the body and the other organs. Think of just the size of the macula compared to the overall heart, the kidneys, or the liver, and any biochemical markers that might leak into the blood supply are minimal compared to those that would leak in from the other organs. Furthermore, in the retina, there's a blood-retinal barrier, much like the blood-brain barrier, which prevents molecules from getting from the retina into the bloodstream, thereby making it even more unlikely they will bind significant biomarkers that can guide us in the management of. Around 2005, 2006, and especially after Lucentis was first approved in 2006, we began routinely injecting anti-VEGF drugs into the vitreous gel. At that time, appeared that it might be worthwhile that at the time of injection, we might be able to sample small amounts of vitreous in the office and be able to look at biomarkers within the vitreous which actively bathe the retina and the macula specifically. So we began in 2006, 2007 to figure out ways to aspirate tiny amounts of fluid from the vitreous and then develop bioassays that would allow us to measure hundreds of proteins within these tiny. In the past, we've been focused on VEGF as an important component of the response to retinal and choroidal disease, but it turns out that there are a host of other biomarkers that bear scrutiny, and we have to take our blinders off and look at other biomarkers. Technological advances, we've been able to develop a rapid microarray assay to be able to measure hundreds of proteins in fluid samples as small as 20 microliters. We've developed a microsampler that can allow us to get these tiny samples. We use reverse phase protein microarrays that allow us to rapidly assay for all these hundreds. And the reverse phase protein microarray technology that we have developed has allowed us to look at 72 samples at one time on a single slide the size of a typical microscope slide. Since our advances recently, as we've moved down to the biopark at the University of Maryland, we've been able to improve this so that now we can look at 1,056 samples at one time using far less fluid, enhanced microarray assays. This is the old assay, and you can see the roughly 70 some odd spots on this slide. On the same size slide, with the advanced technology that we've been able to implement, you can now see that there's 1,056. So the spots are much, much smaller. This is all automated. There's no way that this could be done. So we've been performing diagnostic vitreous sampling, and we've sampled approximately 4,000 samples. There's been no increase in risk at the time of or as a result of acquiring the sample. So it's safe to do. We can do it in the office. It adds an extra few seconds to the process, and we're able to get these vitreous samples that we can then evaluate. So one of the things I want to talk about is vitreous proteomics reveals a biomarker panel that can predict the response of AMD patients. I am, as a disclosure, president of Ocular Proteomics LLC, which has been formed to delineate biochemical pathways of ocular disease in order to identify novel biomarkers that assist in the treatment and management of, as well as new drug discovery. There are no products that this company is. This was all done under IR. And again, we want to look at a host of biomarkers in addition to. The studies have allowed us to approach three different main categories. One is how can we aid in the management of disease? The second is characterization of disease. The third is staging of disease. So let's begin by how we can look at how these biomarkers can aid us in the management. We've looked at the proteomic analysis of in-office vitreous aspirates in the Treat and Extend protocol. In these eyes, they had 3 monthly injections of anti-VEGF, followed by a variable extended period depending upon either decreased vision or increased macular edema triggering retreatment. Among these patients, we divided them into stable visual acuity and unstable visual acuity in terms of response, their demographics. And we looked at a series or a whole panel of biomarkers that included biomarkers that were representative of the process of angiogenesis, biomarkers representative of apoptosis or cellular survival, those that are indicative of oxidative stress, also biomarkers associated with inflammation, and biomarkers from the complement. So we divided these patients in Treat and Extend into two groups. Those with stable visual acuity, with vision within 3 ETDRS lines, and they received treatment due to increased macular thickness, and unstable visual acuity patients who were treated due to a decrease in vision of greater than 3 ETDRS. Vitreous protein predict, or can a vitreous protein predict, when Treat and Extend? Well, we found that 2 biomarkers had significance in terms of differentiating between those that might be amenable to retreatment. And each treatment produced. What is a ROC curve? A ROC curve allows us to measure the ability of a biomarker to differentiate. So the ideal biomarker, and this is the situation where the controls do not overlap at all with the disease, shows a ROC curve that looks like this on your right. And when we first start out doing the analysis, if you put the cutoff point low, you can see that there's a 100% false positive, but 100% true positive. As we raise up the marker, we get fewer and fewer false positives, but maintain the true positives, until we get to the point here where we keep 100% true positives and no false positives. And that's the there's some overlap. And this allows us to identify the amount of overlap that there is by using these ROC curves. So in the real world, we start out with the cutoff point being low, and again, 100% false positive and 100% true positive. But as we come down, we can see that there's some overlap where there's some false positives, but still a high level of true positive. The same at this point. And then as we go forward, we then drop down to 0 false positive curve. When we looked at patients before and after the extension period, we saw 2 molecules with good ROC curves. One was MMP9, and the second was PTGF receptor, not the actual PTGF cytokine, but the receptor, tyrosine 716. And the area under the curve was 93%, which is a very, very good delineation or differentiation between those that can before and after the extension period. So PTGF beta receptor is a good predictor of when treat and extend patients may need retreatment. And we're looking at this further to further establish whether this is a protein predict if a patient should be on treat and extend to begin with, and so that we can decide whether we should. Well, we looked at the whole panel of proteins, and we found 2 proteins that had significant differentiation. One was, interestingly, VEGF receptor Y951, and also a different PTGF receptor, this one Y751. And you can see the p-value. Combining the two, we got even better p-values of 0.004. Combining PTGF receptor and VEGF receptor, they were the most predictive of whether or not a patient could be even started on treat and extend. Rather than start somebody on treat and extend and allow the vision to deteriorate, we can start to predict ahead of time whether a patient will be even potentially successful in that strategy, and thereby not risking any vision loss before starting them on it. And therefore, we're looking further whether the vitreous levels of PTGF receptor and VEGF receptor might be an indication if a patient will respond. Protein in the vitreous of patients with AMD have potential to be predictive biomarkers. PTGF Y751 and VEGF Y951 could tell us whether a patient will respond. And then MMP9 and a different PTGF receptor may be a predictor of when a patient is going to need retreatment rather than waiting for retreat. What about characterization? Well, AMD is a heterogeneous disease, which is probably a wastebasket of diseases, and there are probably multiple diseases within the overall. We know that RAP lesions, retinal angiomatous proliferation, which were first described in 2001, are a subset of macular degeneration, where the neovascularization actually starts within the retina. You can see on the right-hand panel that there's marked where the neovascularization is actually starting within the retina before it dives down into the choroid. It turns out about 30% of patients with wet AMD have this intraretinal neovascularization as the initiating. How can we best differentiate those RAP lesions from the actual sort of more classic choroidal neovascularization? Well, imaging can do it in some cases, but it's very difficult and requires very sophisticated equipment. So we wanted to see if there are biochemical differences between RAP lesions or eyes with RAP lesions and eyes with So we found that when we compared eyes with RAP lesions to choroidal neovascularization, these 5 proteins seem to show significant differences. When we looked at it further, the most significant differences were for MMP14 and TIMP2. Now, these are enzymes that are both involved with the invasion of tissue by either tumors and these proteins are enzymes that digest the surrounding extracellular matrix and allow the tips of new blood vessels to actually. And interestingly, they seem to be elevated in eyes with RAP lesions. Where else do you see elevated MMP14 and TIMP2 in neural disease? Well, because the retina, after all, is neural tissue. Well, it's interesting that the highest levels are seen in glioblastoma, which is the most invasive primary neural tumor. And they have glioblastomas have high levels of MMP14 and TIMP2 as well. So with RAP lesions, MMP14 and TIMP2 may be key elements that allow the neovascularization to invade from the retina through the choroid. What about those eyes with choroidal neovascularization and no RAP lesions? Those seem to have the highest or most significant levels or elevations of complement C9 and complement factor H, which has been seen genetically to be linked. Complement factor H is an inhibitor of the whole complement cascade, and therefore, if it is impaired, it can cause increase in neovascularization and inflammation, and also actually increase in MMP. So, RAP lesions, which occur as intraretinal neovascularization, seem to be highest in MMP14 and TIMP2, which may be diagnostic markers of this disease. And choroidal neovascularization seems to be associated with elevated complement 9 and complement factor H. Issue is whether we can use the protein biomarker. So we looked at the various biomarkers, and we found that levels of MMP9, which is another invasive protein associated actually with invasion into tissues like the vitreous itself with type 2 collagen, that this seemed to be associated with the levels of visual outcomes in eyes with proliferative diabetic retinopathy. And we found that MMP9, when it was higher, it tended to correlate with better visual. In patients with visual acuity better than 2200, MMP9 has a strong correlation with pro-inflammatory cytokines. As you can see here, things like interleukin 12, interleukin 1 beta, MMP2, FGF basic, IL-6, and bad serine. With visual acuity 2200 or worse, MMP9 had strong correlations with pro-angiogenic cytokines. As you see here, things like c-KIT, PTGF receptor, TNF-alpha, VEGF-A, VEGF receptor, and a few different VEGF receptor molecules. So it seemed like MMP9 was part of the pathway for angiogenesis in eyes. To make sense. So what's the future? We're starting a multi-center trial to look at biomarkers more aggressively to better understand how these biomarkers can help us in the management of ocular disease. And we're doing this in collaboration with a few different sites around the country, including a site in Cleveland run by Larry Singerman, a large site in Chicago run by Kirk Packo, and Rick Ferris at the National Eye Institute. Thank you very much.